This scan shows the sphenoid and the sellar and the parasellar structures, chiefly the parasellar carotids, in a patient who has been diagnosed with a functional pituitary adenoma. This patient has acromegaly, and as you see, there is a well-defined lesion in the sellar, slightly on more towards the right side, with contact. And this patient being acromegaly and a secreting tumor is a particularly complex situation because acromegaly patients with hypergrowth hormone also pose a risk because of possibilities of vascular injury, higher incidence of CSF leak, as well as in general hypervascularity in the sellar, the sphenoid region. And that could obviously flag it as a slightly higher risk as compared to ordinary non-functioning tumors. And even in functioning tumors, the growth hormone secreting tumors are considered to be high risk vis-a-vis while comparing it to non-growth hormone secreting tumors. So unlike non-growth hormone secreting tumors in the midline, in a growth hormone secreting tumor, we opt for a larger approach just for planning contingency measures. Though the aim is to completely excise, but sometimes if some remnant is left behind and we feel that the risk of vascular injury or hemorrhage or CSF leak is too high, then sometimes uh, radiation to the remnant can also be planned. You see, as against the standard bilateral extended sphenoidotomy for a sellar approach, here because of this potential problem of a growth hormone secreting tumor and expectations of hypervascularity, we are opting for a slightly larger approach. We have conducted both an anterior and posterior ethmoidectomy. You can see the anterior ethmoidal artery onto the 11 o'clock position on the screen. And now we are trying to encompass the entire sphenoid into the nasal cavity along with the anterior and posterior ethmoids so that our vision is larger and we could also uh, have a higher instrument manipulation space inside the surgical field, which usually may not be requirement in every patient of a routine sellar approach. On extended sphenoidotomy or uh, situations where we encompass the ethmoids is generally used for parasellar or suprasellar extensions of these adenomas. And sometimes if the parasellar extension is too much, then we may also opt for the transpterigoid route to extend our lateral exposure. Here our approach would be uh, something called 1.5 times or 1.5 sides of sphenoidotomy, where on the right side, where the site is dominant and there's lesion, we would go for a routine extended sphenoidotomy, which is transnasally, and we would go wide the nasal cavity. We have taken down the lateral nasal wall, and on the left side, we'll use a transseptal approach, which basically means we would not violate the lateral nasal wall, and we would also not violate the septal pedicle. Because sometimes when you're taking the anterior face of sphenoid too low, the septal pedicle can get injured or it may have to be willfully sacrificed. Here, we want to keep the lateral wall untouched, and hence on the left side, which is the side where the tumor is lesser so, we would just give a septoplasty incision, go laterally, and conduct a sphenoidotomy from the transseptal side and not the transnasal, which we did on the right side. The goal is again to have adequate space for instrumentation and visibility, our drilling. So you see that though it looks a little strange, but in the end, the outcomes and the healings are very good because once the septal flap on this side, on the left side, is put back, the left nasal cavity heals very beautifully because the lateral nasal wall has not been touched at all, and the septal flap is also intact. So this helps in both achieving an early healing, preserving the septal pedicle at least on one side without compromising exposure, as well as avoiding any loss of olfaction. Sometimes if we go too high and if we make a very large posterior septectomy, we could have loss of olfaction in these patients. But if we are preserving at least one side, we can be very sure that the loss of olfaction can only be partial and not complete. So you see how on this side we have taken down some bit of posterior septum, and this is the keel. And now we are taking down the keel, this part of the sphenoid bone. You could drill and you could use a chisel and hammer as well. Just make sure it's not a very big fragment that you're trying to pull out, because it can lacerate your flap as well as nasal cavity and lead to sinus deformation. So once a reasonable amount of bone has been removed, the rest of it will be managed by drilling. So you see already how adequate and wide our exposure looks even at this stage, where we are going, as you see, transseptally from within the septal flap on the left side. And even with that, it gives you a very good clean access of instrumentation, because for most part our trajectory of working is midline, which is rather easy with this approach. Now we'll remove the mucosa of sphenoid to gain access to the sellar. Now you see a very thick intersphenoid septum in this patient, which has to be taken down. These intersinus septa could be thin or thick, and could be bifurcate or trifurcate, and could have attachments in the to the carotid. One has to be cautious in not avulsing them. They could be either taken down with through cuts or drilled, but through cuts must be avoided for very thick bone, because those through cuts are rather fragile instruments and they can be broken. So removal of the mucosa of the sphenoid is a very important step to commence our overall drilling. That can lead to a slight amount of venous ooze from the bone, and that's fine. Now you see that for most part, as of now, our both sides of septal flap are intact, which basically means we have not violated the septal artery on either side. And should one need a septal flap for any contingency measures, either now or later for a recurrent or revision surgery, then that is surely possible, which is not the case if you have taken down one or both of the septal arteries. Now, this is the starting and the crude part of the surgery. So, we're using a cutting burr here to drill down the thick septa. And once you go posteriorly, superiorly approach the superior wall or the sella, then you can probably use a diamond burr to avoid any inadvertent injury to the sphenoid structures. Now, the advantage of a sellar approach is that the sella lies in the superior trajectory and it's head on, and you do not need to worry too much about the inferior part of it. A transclival approach, though it's straight head on, but it's very, very different in terms of the inferior drilling that one has to do, and one has to work in the depths. That increases the distance of working as well as the depth. In a purely sellar approach, it's not. It's pretty much straightforward. So this is the bone that overlies the paraclival carotid, these septations. It can be taken down partially just to get ease of instrumentation. Otherwise, we don't have much business going towards the paraclival carotids in a purely sellar surgery. So we are just trying to, you can see how, now normally these septa may not be very thick, but you see what I was saying in the beginning, that uh, acromegaly patients and patients with growth hormone secreting tumors, which have been there for quite number of years, have obviously a far, far thicker bone of the sphenoid and vascularity as compared to patients who have non-growth hormone secreting or non-secreting adenomas. Sometimes the bones are so thin they can be simply fractured using elevators or gentle taps, and even a good diamond burr can break this off. But you can see here that the bone is rather thick, and you'll see that it's also fairly vascular. This is the clival recess, as you see, and the clival recess is between the sella superiorly and both the paraclival carotids on the lateral side. You see some bony bleed happening here post the avulsion of the mucosa. And now at this stage, once we have cleared a thick bone from the sphenoid sinus, now we are drilling on the sellar face, and now we will resort to our diamond burr, and you will still see that again this bone is pretty thick, and unlike normal sellar surgeries, it doesn't come off so easily as it does usually. So venous ooze also can sometimes irritate in this surgery. We are seeing that we are again just creating more space for drilling all around, as well as for the blood to pool in, so that it doesn't hamper our surgical field. The fundamental part about any sellar surgery, whether it is functioning or non-functioning tumors, apart from, of course, the completeness of the procedure, is also the fact that you must know your lateral boundaries, which are basically the paracellular carotids. So here in these situations, we all times use both the navigation system and the Doppler for our intraoperative correlation. So we'd not like to leave anything on chance. The sellar carotids can be remarkably variant in all the patients we operate, much more so in growth hormone secreting tumors, and we prefer to use both intraoperative navigation as well as the use of Doppler to assess the risk in a particular patient and to assess the distance of both the carotids from each other and the amount of tissue we have in between. That's really important to avoid complications. Ordinarily, CSF leak is not very common in these surgeries, but again, once it is about a growth hormone skin tumor, we obviously counsel the patients. As you see here, despite some drilling, you can see how thick, how robust the bone is, and it starts to ooze in from all the places, which usually it does not in a routine sellar lesion. Often, the sellar has been made so thin by the lesion that it can simply break by a gentle tap of the elevator without any force or hammer. But here, you see that how even a fair amount of drilling does not is not enough to open the sellar. Once again, one must be cautious that we are on the lateral side. There are the cellular carotids. Sometimes they could be very, very medial, like kissing carotids. So one has to be very sure with your drilling. One has to keep moving the drill and not exert any pressure anywhere, because though the diamond drill is safe, but any exerted pressure can very easily rupture a vessel. Now, this is a 3 or a 4 hand approach where you see that constantly there's irrigation, there's constant drilling. It's not just a little drilling and then suctioning and a little drilling again, because that is frustrating. That wastes time and energy. So it's about the fact that endoscope, suction, irrigation, and drilling all happen together, and that is the point and the value of the two nostril approach. Usually two nostril, but in our case we like to call it 1.5 nostril, where we are going transnasal on one side, the dominant side, and transseptal on the other side to reduce the to reduce the nasal trauma. Now you see, for most part, a lot of places the bone has been thinned out, and the rest of it we'll try to flake or remove using uh, a kerosene sponge. You know, these sponges are wonderful tools. They come in various sizes. You must have different kinds of size and angulations, and must be careful. Very large punching post this step is not recommended and is counter suggested. One must punch in small bites and be patient. It's very important. And one must be knowing very carefully that it's the bone indeed that you're punching, because if you punch too aggressively, then it is almost certain that you will also punch out the carotid wall as well, leading to a fatal hemorrhage. You can already see the shadow of the carotid onto the right side and see the vessel shadow, which will soon be cross-checked and verified using a Doppler probe. Now, why both things, Doppler and navigation, is because we want to rely on both things together, as well as our clinical instincts and the anatomical landmarks, and not just one. Both are electronic tools and can misguide you at times if clinical sense does not prevail. You see how this is thick bone now, and you see how venous bleeding can start here, mostly from the inferior intercavernous sinus. And these bleeds can sometimes be significant and bothersome, again, more so in patients of growth hormone secreting tumors. Usually, an attempt to coagulate them is not helpful. So it's a good idea to simply use some Surgicel on this venous bleeding and use some cottonoid with a little slight pressure for this bleed to settle down. Unnecessary cautery can only harm and not help in this situation. So once again, we are very, very cautiously taking down the lateral bone up to the level of the internal carotids to be sure that we have made adequate exposure before we open the periosteum and the dura of the sella. Now you see we have made a plane inside for our future fascia to set in. We are creating just a layer of plane between the bone and the dura. And once again, we do not wish to take down the inferior bone too much because that acts as crucial support for the sella. As we go very inferiorly and as we go superiorly, both the sides, both the locations, we will encounter an intercavernous sinus bleeding, which obviously is much more in hypervascular states such as meningiomas and growth hormone secreting tumors or sometimes malignancies. Now, once we have seen that, we are basically using the navigator probe here to find out the approximate level of all the critical structures, approximate angulation for the instrumentations to go for the tumor, and also to see how much more bone we need to remove. It's also very easy in this step to get misled or get conflicted about the potential midline. So one must stay in the midline. This is being operated along with our neurosurgical team, with Dr. Anurag Saxena and his team. So we use a forehand approach where one surgeon can constantly operate inside the cellar, while the other surgeon uses the suction and a good visualization for the surgery to continue happening peacefully and clearly. This is the Doppler probe as you see here, and we're using the Doppler probe to map the carotids. And once that has been done, we have a fair assessment of where our vessels lie. After that, we will resort to incising the periosteum and the dura with a scissor. Once this has been done, we use some coagulation of the sellar face, the sellar periosteum and dura, both at the superior and inferior aspects and sometimes broadly on the surface. This reduces the vascularity of dura and any small vessels that obviously lie beneath it, which is quite common in hypervascular tumors. And now that has been done, we will resort to a cruciate incision to open the sellar face and go inside the tumor. The depth of incision has to be controlled. It has to be gradually peeled and cut rather than going very deep. And you see how that, unlike a usual sellar pathology, every bit of incision, every bit of bone removal instigates visible amount of venous bleed in these patients because of the extreme vascularity, and that obviously renders these growth hormone secreting tumors as a particular high risk. Uh, Apart from other indications such as post-radiation therapy, patients on bromocriptine, carbagoline for a long time because of fibrosis, or for patients who have a cross involvement of the internal carotid. Also, the suction that we use here is basically a very fine suction. It's a controlled suction with an olive tip. It's not a large uncontrolled suction because even a very strong uncontrolled suction can cause significant trauma to the surgical field and to the intracellular structures. So at the outside itself, you can see the yellowish tumor lurking inside the sella, and the first part is to just uh, disattach it or release it from the rest of the pituitary gland, And for that, we use a curette, ordinarily avoiding pulling, except for biopsy purpose. Sometimes, and in fact, more than sometimes, these growth hormone-secreting tumors could be very fibrous. They could be adhered as compared to non-secreting tumors or non-growth hormone-secreting tumors, and that could place a lot of risk onto the internal carotids or to the brain. And sometimes there could be additions to the important perforators. At all points of time, one must understand, one must quantify risk as to what can be and what cannot be. And here, an attempt is being done to release the tumor tissue by using a blunt curette all around. The incision is slightly being enlarged to give us more working space. Now you see how with the curette, it's again very difficult because unlike a normal liquidy or a suckable tumor, this is not a suckable tumor, and it's quite firmly adherent to the insides of the sellar, including the vessel and sometimes the diaphragm, which can lead to CSF leaks. And you see how also having more than one hand is so important in these procedures. With holding endoscope, it's almost impossible to just manage them with a single hand. So you can assess that it's very densely adhered. It has been obtained for biopsy, and the rest of it is being tried to get cleared using a curette. As you see this. So one has to be patient in these patients because the tumor can have very heterogeneous consistency. Certain portions can be tougher and more adhered and fibrous or hard as compared to other portions of the tumor. And one has to also have a very fair risk assessment as to what level do you want the surgery to carry, because sometimes if it is too firmly adhered to the carotid, it must then one a call intraoperative call could be made as to when to stop. And now you see here how the adheredness of this tumor to the diaphragm has already led to a CSF leak, and how you can see the CSF coming because these tumors are frankly very adherent, and that is the problem with all growth hormone secreting tumors. So it's not a big issue to have a CSF leak, although these are normally slightly higher than usual pressure leaks. So one has to be cautious in terms of using a good tight closure in these patients. So we use fat and fascia, and ordinarily we do not wish to use halal flaps in all these patients because we reserve it for later. You can see how the contents are being pulled, so it is stopped in order to not uh, put any pressure onto the rest of the intracellular contents and the diaphragm which has been pulled because of the traction on the tumor. So hemostasis is also very important at the same time. So hemostasis usually we avoid using bipolars here, and we do not want to coagulate any vessel. Many of these are end arteries. So all you want to use is using some small cottonoids to basically just clear, put some light tamponade onto the ooze, which usually settles down. All the packs have been removed. It's very important to achieve hemostasis, which we do using some amount of flow seal to basically create some hemostasis and avoid bleeding inside the cellar. And more so, one has to be very, very cautious because now the intradural space has been violated. More than just the bleeding and the volume of bleeding, what is also concerning is that if any hemorrhage happens from here, it has the potential to go inside the intradural space and cause intradural hemorrhage, which could be a catastrophe. So here now we would use fat to close this wound. Use a long-tailed fat to put in this sellar defect to stop the bleeding. It does so with ease. Post which we will use a facial out of graft for the thigh to cover this. We prefer to have a reasonably tight seal because some of it would quite definitely reabsorb, making it loose, and avoiding stopping CSF leak is paramount to avoiding meningitis in these patients. And now you see that post the fat, using a thick um, facial out of free graft to place on the fat, and it's already the CSF leak has closed. Somehow, sometimes if the leak is even bigger than this or is not managing, then it would also be prudent to use the hadad or the septal flap on top of it. It's very important to neatly and cleanly oppose the facial atta graft against the bone all around, so that it takes attachment on the bone apart from the fat that it is already contacting on the sellar. And once this fascia graft has been adequately placed in contact with the bone, then in the end we would use some uh, gel foam on this layer to be placed eventually.